So now that we know that disorders of sodium are very common in the hospital, there's other electrolyte abnormalities that you should also be aware of. These include disorders of potassium, magnesium, and phosphorus, which I'll cover in this lecture. Here are the learning objectives for this lecture, and the recommended reading. I'd also recommend that you go back to prior lectures that you've had on these topics if you need a further review. So a normal potassium is 3.5 to 5, and often you don't see symptoms until the potassium is less than 3 for hypokalemia. As for the symptoms of hypokalemia, we'll think of what happens if the extracellular to the intracellular potassium is decreased. It's going to slow down the action potential, so muscles are going to be weak. This includes all the muscles of the body, so you'll have generalized weakness, decreased peristalsis of the GI tract, and arrhythmias due to cardiac muscle. The common EKG findings include ST depressions, T-wave flattening, and U-wave formation, and really you just have to memorize this. However, remember that hypokalemia is also typically provoked by hypomagnesemia, which potentiates arrhythmias, so you need to check the magnesium also. Always remember that severe hypokalemia can cause rhabdomyolysis. Basically, you're starving the muscle of the action potential, which precipitates muscle breakdown. I like to think of the causes of hypokalemia as twofold. It's basically an internal balance problem, which is movement from the extracellular space to the intracellular space, or an external balance problem, which is much more common. Now, internal balance problems, there are several different causes, such as insulin. Think of like a DKA patient when you put them on an insulin drip. This is going to drop their potassium, so you have to replace their potassium at the same time. I'll talk about this further in that lecture. Also, beta agonists can cause an internal balance problem, and also increased cellular uptake, such as after replacement of vitamin B12 and folic acid, can cause your potassium to drop. External balance problem, the primary reason is excess loss, such as nausea, vomiting, and diarrhea. However, it could also be decreased intake. However, this is very rare. There are some algorithms for how to further work up hypokalemia if one of these causes isn't apparent. However, these are rarely used. I've only used them a couple times since I've been in internal medicine. I'm honestly not going to expect you to remember these, but it might be good to look these up on UpToDate and put them in your peripheral brain. As far as the treatment for hypokalemia, there's a general rule where 10 milliequivalents will raise your potassium by 0.1. However, this could be as much as 20 milliequivalents. Remember, normal potassium is 3.5 to 5, so I like to just make my goal as 4.0 just to make it easier. You can typically replace this over 4 to 8 hours, and you can give it either oral or IV. Oral is typically given as 20 to 40 milliequivalents at a time, or IV can be 20 milliequivalents at a time, followed by a small break, and then you give more. However, you can give up to 40 milliequivalents at a time via a central line. Remember, potassium is used in the lethal injection cocktail, so you never want to push potassium very quickly, as this would stop the heart. Always remember that hypomagnesemia can cause hypokalemia, so you have to check it. Anytime the potassium is low, automatically ask yourself, what is the magnesium? When you do find the magnesium is low, you should replace this first and then replace the potassium. To further demonstrate that, here's an example. Let's say you have a 40-year-old male admitted for C. diff colitis. Labs reveal magnesium of 1.2 and a potassium of 2.8. So what is the cause of the hypokalemia and hypomagnesemia? Really, for this patient, it's apparent. I mean, the patient probably has severe diarrhea, so the patient is losing potassium and magnesium. So how would you treat this patient? Well, remember first, you need to replace the magnesium, so this patient would probably benefit from some IV potassium or IV magnesium, as you want to replace this quickly so that you can then raise the potassium. So they'd probably get anywhere from 2 to 4 grams of mag sulfate IV, and then you would replace the potassium. So if your goal was 4.0 for their potassium, and their potassium is currently 2.8, this would require approximately 120 milliequivalents of potassium to get it back to 4.0. I would probably give the patient 40 milliequivalents of oral potassium along with 40 milliequivalents of IV potassium, and then I'd probably wait 4 hours and then give them another 40 milliequivalents of oral potassium. And then hopefully the next recheck of their electrolytes will show that their potassium is around 4. If it's not, then all you do is give more. Now on to hyperkalemia. This is typically defined as a level greater than 5. However, once the level goes greater than 6, this is where you start seeing fatal arrhythmias. EKG changes you'll see in hyperkalemia. Initially, you'll see peak T waves in a shortened QT interval, followed by increased PR interval, P wave loss, and widened QRS. The workup for hyperkalemia: number 1, you have to repeat it, mainly to rule out pseudo-hyperkalemia. Next, you'll review it, or you'll get a thorough H&P, you'll review their home medications, and their renal function, and an EKG, and typically you'll find the cause. There are many causes of hyperkalemia. Those bolded in red here are the most common, such as pseudo-hyperkalemia. You'll commonly see with hemolysis, and you'll see this in the comments section of the lab report with whatever system you're using. Also, if the patient clenches their fist a lot during the lab draw, that can cause pseudo-hyperkalemia. Another cause is abnormal potassium release from the cells, such as in rhabdomyolysis or tumor lysis syndrome. Another cause is abnormal potassium distribution, and I would say the most common cause is decreased renal excretion, such as in acute kidney injury on chronic kidney disease. There are 3 basic treatments for hyperkalemia, and oftentimes when the potassium is greater than 6, you'll see all of these treatments employed. First is stabilizing the heart, and this is what you use if you see EKG changes. This is done by giving an amp of calcium gluconate. The second way is to shift potassium into the cells. This works rather quickly, but doesn't really last very long. This treatment includes giving IV insulin plus D50, and it lasts about 6 hours. High-dose albuterol nebs can also be used, but this lasts for just a short time. The final way is actually removing potassium from the body, and there's 2 ways to do this. Basically, you give either IV Lasix, and this is only if they don't have kidney disease, because you wouldn't want to hurt their kidney, unless they're volume overloaded, such as in heart failure. Or you can give Kxalate, which is sodium polystyrene sulfonate. This treatment is controversial, mainly because we really don't know how effective it is. However, it's still utilized quite a bit. Remember, it can cause GI side effects and ischemic colitis, which is usually the main contraindication to giving this. The final way is just hemodialysis, and this is the treatment of choice if the patient has hyperkalemia plus oliguric kidney disease, which is less than 400 mL of urine output per day. Now I'll talk about magnesium disorders, which is a primary intracellular cation. It's basically used for protein and nucleic acid synthesis, cell adhesion, enzyme reactions, and modulating channel activity. A normal magnesium level is 1.7 to 2.2. So hypomagnesemia commonly occurs with hypokalemia, so oftentimes the symptoms are the same. You can see that this includes tremors, fasciculations, muscle weakness, carpopedal spasms, seizures, arrhythmias, and hypocalcemia. Usually it's asymptomatic until the magnesium is less than 1.2. Remember the specific signs of hypomagnesemia, such as the Phos sign, which is contraction of the ipsilateral facial muscles by tapping the facial nerve, or the Trousseau sign, which is carpal pedal spasm after inflation above systolic blood pressure. Common causes of hypomagnesemia can either be decreased GI absorption or increased renal excretion. Decreased GI absorption occurs such as in malnutrition or malabsorption or in diarrhea. Increased renal excretion occurs typically with diuretics, cisplatin, or aminoglycosides such as gentamicin, tobramycin, or neomycin. The optimal treatment should be based off of what the actual level is. However, remember that hypokalemia often goes along with hypomagnesemia, and this can lead to deadly arrhythmias. So a lot of times in the hospital, you'll just use IV magnesium to replace it quicker so that you can get their potassium up at the same time. But based off strict hypomagnesemia guidelines, if it is severe, less than 1, these patients should be symptomatic, and you'll typically give magnesium sulfate as 2 to 4 grams IV infused over 12 hours, and then this can be repeated as necessary. If it's mild to moderate, typically these patients are asymptomatic, you can give oral magnesium. However, remember that oral magnesium can cause diarrhea, as it's often present in a lot of stool softeners. So, if the patient already has losses of their magnesium from a GI cause, it may be more beneficial to replace with IV magnesium. Now, I'm not going to spend much time on hypermagnesemia, mainly because it's extremely rare. You primarily see it when you have excess intake plus renal disease. So you always need to check the renal function when you're seeing a patient with hypermagnesemia. Typically, you'll see it with excess intake, such as a patient taking excessive antacids, laxatives, or mag sulfate, such as in refractory asthma or prevention of preeclampsia, but they also have renal disease that contributes to it. The treatment of it is prevention, basically. It's usually self-limited and goes away on its own. However, you can use IV fluids to increase diuresis, and that will usually dilute it out enough to where the kidneys will excrete it out. If they have severe symptoms, you can give IV calcium gluconate, which will antagonize it. Remember, this is one of the treatments for hyperkalemia also. Now on to phosphorus. This is the predominant intracellular anion, and most of it is bound to proteins or lipids. Normal level is 2.5 to 4.5, and it's used for phosphorylation, ATP formation, DNA and RNA synthesis, and cell signaling pathways such as cyclic AMP. So hypophosphatemia is typically a level less than 2.5, and the symptoms are the exact same as hypercalcemia. Remember stones, bones, groans, thrones, and psychiatric overtones. Typically, if the level is less than 2, this is where you'll see muscle weakness, and less than 1 is where you'll see delirium, seizures, coma, heart failure, respiratory failure, rhabdo, and hemolysis. Symptoms usually don't occur until the level is less than 1. The causes, there's 3 main causes. First could be a transcellular shift, such as in respiratory alkalosis or hyperventilation. So think of a patient with sepsis or DKA or severe stress. This causes the pH to rise, which forces phosphorus into the cells. It could also be due to decreased intake, such as in malnutrition, refeeding syndrome, or hungry bone syndrome, or with increased excretion, like when you have too much PTH. So the kidneys can't excrete the kidneys are excreting too much phosphorus. This could also occur if you're giving a phosphate binder, which are more commonly used for the treatment of elevated serum phosphorus levels. Before you begin treatment for hypophosphatemia, it is very important to remember that all phosphorus replacement can bind to calcium, which forms precipitates. and that the treatment can cause decreased calcium, which leads to fatal arrhythmias. So if the hypophosphatemia is mild, typically you can give oral sodium phos or potassium phosphate. If the potassium is greater than 4, you typically use sodium phos, and if it's less than 4, you use potassium phos. Oral is typically given as 250 or 500 milligrams orally, divided 3 times a day with meals, and you usually only give it for 1 to 2 days, and you repeat the level and see how much more replacement you need to give. Also remember that this treatment will cause diarrhea, which will cause decreased absorption. The other option is if they have severe hypophosphatemia, you can give IV phosphorus. This is either potassium phos or sodium phos, and this is the same rule as above. If their K is greater than 4, you give sodium. If it's less than 4, you give potassium phosphate. Typically, and how to calculate this is you give 1 millimole per kilogram of body weight. It's usually around 28 millimoles IV that you'll give TID, and then you'll recheck the phosphorus and see how much more you need to go. Typically, it rises pretty quickly, though, and you don't have to keep replacing it. Now on to hyperphosphatemia. The causes of this can either be cellular lysis, such as in cancer, excessive intake, which is very rare, or decreased renal excretion, which is the most common cause. Remember, 80% of phosphorus is reabsorbed in the proximal tubule. So if you have abnormal renal function, then you can't excrete it. So think of an end-stage renal disease patient. These patients typically require a phosphate binder because they can't excrete any of their phosphorus. So the symptoms are typically related to co-occurring hypocalcemia. I remembered this as the CATS mnemonic, which includes convulsions, arrhythmias, tetany, and spasms or stridor. Remember, though, that phosphorus always binds to calcium, so this can precipitate calcium phosphate in the kidney, which is called phosphate nephropathy. The treatment of hyperphosphatemia is dependent on what the renal function is. If they have normal renal function, then all you have to do is give IV fluids, and it will typically normalize in about 1 day. So you'll repeat the phosphorus the next day and see if it's improved. This is rare, though, as most of the time you'll see this with abnormal renal function. The treatment then, hemodialysis, however, this rarely removes enough of the phosphorus. Therefore, you have to use a phosphate binder. There are several different options here that you can use. First, aluminum hydroxide. However, this causes aluminum toxicity. There's magnesium-containing antacids, which causes hypermagnesemia, plus remember they cause diarrhea. There's calcium carbonate or acetate, which causes calcium to go up, and then there's the non-calcium binders, such as sevelamer. That's newer, and it's typically used in end-stage renal disease patients. However, it is very expensive, and some insurance companies won't cover it no matter what the renal disease is. So please feel free to go back and listen to this if some of it didn't make any sense, or as I had mentioned, you might want to go back to prior lectures you've had on these electrolyte disorders to further clarify your understanding. So here are the sources that I used to make this presentation. Thank you.